Good morning, friends. My dear students, today we'll see the intraoperative hypertension. It is very much important for us because if there is intraoperative hypertension, it may cause myocardial ischemia, myocardial infarction, myocardial damage is there. Therefore, we should not allow intraoperative hypertension. Now, first we will see the definition of intraoperative hypertension. The definition is if blood pressure is more than 140/90. If blood pressure is more than 140/90 up to 160/99, it is called as mild hypertension. If blood pressure is more than 180/110, it is called as severe hypertension. Now, how patient will presentation of intraoperative hypertension? Patient may have hypoxia or hypercarbia. Hypoxia or hypercarbia you can diagnose by seeing SPO or end-tidal CO. This intraoperative hypertension may be due to inadequate analgesia. Third, it may be due to inadequate depth of anesthesia. You can rule out inadequate depth by seeing end-tidal volatile anesthetic concentration. These are the causes of intraoperative hypertension. Then you should look for the iatrogenic causes. Iatrogenic causes mean if you have given adrenaline containing solutions, you can rule out. If you have given any wrong drug, vasopressors or adrenaline containing drugs, then these are the medication errors. Next, you should check the instrumental errors. If there is NIBP is working properly or not. Then if you are monitoring patient on IBP, intra-arterial monitoring, you should look the transducer if it is proper or not. Then IV drugs, TIVA pump is properly working or not. You should rule out that. Then IV line is proper or not. These are the reasons to look for. Then you should rule out whether the patient is having preeclampsia. Suppose patient is of more than 20 weeks of gestation, he is showing intraoperative hypertension. You should rule out proteinuria. If there is proteinuria, platelet count, liver function test, this should be ruled out. These are the things, these are the presentations. Whether patient is having thyroid storm, you should rule out. Whether there is thyroid storm, whether there is pheochromocytoma. These are the things. Then immediate management. How will you manage such patients intraoperatively? ABC. That means first look for ABC. This is an emergency condition, intraoperative hypertension, airway, breathing and circulation. Then what you will do? ABC. Then you should give 100% oxygen. FiO2 should be 100%. Why? Because there should not be hypoxia or hypercarbia. To avoid that, give FiO2 100%. Then stop the surgeon. Wait till the blood pressure is controlled. Then increase the depth of anesthesia. How will you increase? Increase the concentration of inhalational anesthetic agents. Then give, if there is inadequate analgesia, give another dose of opioid, fentanyl, 0.5 microgram per kg, additional dose. You have increased the depth of anesthesia, you have increased the analgesia also, then you have increased the FiO2 100% also. Still it is not functioning. Then there is a role of vasodilators and beta blockers. Which vasodilators? There are 3 vasodilators. Number 1, NTG. This is the most common use of glyceryl trinitrate, NTG. How much it should be given? It should be given 50 mg in 50 ml at a rate 3 ml per hour. Then you can give, so if it is very resistant hypertension, you can give sodium nitroprusside. So dose of sodium nitroprusside 0.5 to 1.5 mg. This can be given. Then there is a role of beta blockers. Which beta blockers? You can give metoprolol. Metoprolol 1 to 2 mg can be given. Another dose, another drug, labetalol. How much labetalol? 5 to 10 mg in increments. Third drug of choice is ismolol. How much dose of ismolol? Ismolol is given by 0.5 milligram, 0.5 milligram per kg. It is a bolus or loading dose, and it is followed by 0.05 milligram per kg per minute. This is a maintenance dose. This will be the treatment. Then what subsequent management you will do? Subsequent management will consider you should do the 12 lead ECG. Then 12 lead ECG. Post-operatively you will do 12 lead ECG. You can do cardiac in troponin. If cardiac troponin can be done, 12 lead ECG can be done. These are the investigations. Then you should rule out thyroid function test. Then 24-hour urinary catecholamines for detection of pheochromocytoma. These are the investigations you will do. Then what are the risk factors? Which patients are more prone for intraoperative hypertension? These patients are white coat hypertension or essential hypertension. These patients are not receiving any type of treatment. Then patient of aortic clamping. If there is aortic clamping surgery, these patients are more prone for the hypertension. Then patients receiving MAO, monoamine oxidase inhibitor, and they have received pethidine, they are hypertension. If patient is receiving ketamine, there will be hypertension. Then there is a family history of metabolic neoplasia. Then there is a head injury. These patients are more prone for the intraoperative hypertension. During intraoperative hypertension, if you are suspecting intracranial hypertension, at that point you should advise CT scan of the patient. Post-operative, you advise CT scan. You should manage by giving propped up position, controlled hyperventilation. You can consider mannitol. This is the treatment and successive management and investigations for the patient of intraoperative hypertension. Thank you.